Hi, my name is Beaubrun, and I'm a board-certified behavior analyst with Brett and Associates. In this video, we'll be talking about practicing cultural humility, specifically language preference. The BCBA task list areas are F8, conducting functional analysis of problem behavior, F9, interpret functional assessment data, and H9, collaboration with others who support and provide service to clients. As demographics continue to shift, so should practice that responds to cultural responsive needs. The Ethics Code for Behavior Analysts, updated January 2022, includes Area 1.07, Cultural Responsiveness and Diversity. Cultural competence is the ability to understand, appreciate, and interact with people from different cultures or belief systems different from your own. When practitioners incorporate cultural competence into treatment, it may lead to improved outcomes, increase client satisfaction, and motivate clients to be equal partners within their care and clinical team. Increasing cultural understanding and diversity in applied behavior analysis is critical to culturally responsive treatment. One factor to consider when practicing cultural humility is language preference when treatment planning for behaviors targeted for decrease and increase. In the Rispoli et al. Article, the researchers evaluated the influence of language implementation on functional analysis outcomes for a child diagnosed with an intellectual disability. The participant was a 5-year-old girl diagnosed with severe intellectual disability and cerebral palsy, and resided in a home where Spanish was the primary language spoken. During the functional analysis, challenging behavior was assessed during 5-minute sessions under 4 conditions: attention, play verbal, play nonverbal, and demand, across 2 phases. Implementation is English as well as Spanish. This may suggest that in the participant's reinforcement history, she accessed more reinforcement for challenging behaviors in situations where English was spoken. For example, challenging behavior was more likely to be reinforced at school versus at home, since English was spoken at school, where demands are placed and attention is divided among other learners. Behavior analytically speaking, English could have served as an SD and Spanish as an S delta for reinforcement of challenging behaviors. It's also possible that English occasioned more problem behaviors because the child did not understand English as well as she understood Spanish. A limitation of this study was that the researchers did not evaluate interventions. In this instance, as behavior analysts design their treatment plans, function-based treatment should include functionally equivalent behaviors to access attention and escape from demands. Language preference research for English language learners who use augmentative and alternative communications is also limited. In the Kuntz et al. Article, the researchers sought to extend this line of research. The participant was a 10-year-old boy diagnosed with Down syndrome. The participant's family spoke Spanish, but he attended an English-only elementary school with no Spanish-speaking faculty. The student used a single-button speech-generating device that could access both English and Spanish vocabulary. Each device, an application on an iPad, produced the same volume of speech output, displayed identical pictures, and had identical cases and colors corresponding to each language. A color and conditional discrimination assessment were conducted to ensure the participant could match and discriminate colors. During the pre-session, the participant had access to toys, and the single-button speech-generating device was not available. Every 15 seconds to 1 minute, the interventionist provided verbal statements in the designated language, English or Spanish, or remained silent during the control condition. During the man condition, the single-button speech-generating device was available to the participant. Once a request was made, all devices were removed, and the selected edible was provided. After the edible was consumed, the device was returned. Each session lasted 5 minutes. The sequence was repeated for each condition: English, Spanish, and control. As a result, the participant averaged 35 Spanish mans per session over the final 3 sessions, and 2.67 mans per session during the English and control conditions during the same period. A limitation of this study was that there was only 1 participant. Another limitation was that the measurement of social validity was not formally assessed. I'm currently working with a student who is multilingual, English and Spanish. He recently returned to school in a hybrid model, both in person and virtual. While schools were closed due to a global pandemic, the student spent the majority of his time with his grandparents who spoke Spanish. At school, the student engaged in high rates of vocal stereotypy. Some words and phrases were unintelligible, and some were not. It was possible that what was assumed to be an unintelligible word was simply a word that was not spoken in English. The speech therapist provided the student with an augmentative alternative communication device with 4 icons: go, hello, more, and stop. I'm collaborating with the speech therapist to facilitate the student's use of the device. The icons should be available in Spanish as well as English. It's important to increase cultural competence in behavior analytic practice by professionals working with culturally diverse populations. Thanks so much for watching. Please subscribe to our YouTube channel, and to disseminate the science, share this video.